Ischemic heart disease can also be called coronary artery disease. It used to be called atherosclerotic disease. But whether you call it ischemia, coronary disease, or atherosclerotic disease, it all means the same thing. It means my blood vessels, she's clogged up, she's too tight, I'm not getting enough blood. I'm not getting enough blood. And what's happening? My heart is so upset. My heart is broken. I'm not getting enough love from you. Not enough flow of love. Look at this. Imbalance between. Yeah, that's called I'm starving to death and I'm going to die if you don't come to me soon. The blood flow is insufficient. In other words, oxygen delivery. Oxygen delivery to the heart. Oxygen delivery to the heart is a function of three things. It's a function of your cardiac output times how much hemoglobin or hematocrit do you have times what is the percentage of saturation. So if you can't deliver blood because you're anemic, the heart starts to get ischemic. If you become hypoxic, the heart becomes ischemic. If you have no cardiac output, the heart becomes ischemic. The heart can't tell the difference between hypoxia, anemia, decreased cardiac output, or carbon monoxide poisoning. Carbon monoxide poisoning, you die of an infarction. Carbon monoxide, see here, imbalance between supply and demand, carbon monoxide poisoning. The hemoglobin's not giving it up to the tissue. The hemoglobin's not giving it up to the tissue. It's not releasing it to the tissue. So carbon monoxide poisoning causes an infarction. Now, the plaque ruptures. What happens here is that when you have a blood vessel, you have a blood vessel, and on the inside of the blood vessel, we got some endothelium. And what happens with the endothelium is that the endothelium starts to get all clogged up with some yucky, nasty, crappy, lipidy stuff. And the lipids get built up underneath there. And what ends up happening is that sometimes that plaque, boom, ruptures. And what happens is that platelets form on top of that ruptured plaque, and ding, 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 ischemia. You rupture a plaque, it bursts, it sends out fibrin, it sends out von Willebrand's factor, it sends out signals like platelet, 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 and the platelets attach, and it clogs up the blood vessels. So that's why the basic management at the beginning here is to give the person antiplatelet drugs, and then later on, platelet plaques get stabilized. Platelet plaques get stabilized by fibrin. Platelet plaques get stabilized by fibrin. Why don't we all become platelet statues? Because the platelet plaque gets cross-linked up and stabilized by fibrin. Now, fibrin is made out of fibrinogen, and fibrin itself would get chopped up. Fibrin itself would get chopped up. Fibrin would get chopped up by plasmin. If another factor called factor 13 comes and links up the fibrin, and factor 13 stabilizes that clot, preserves the clot, and after the clot has been stabilized by factor 13, plasmin won't chop it up. What's the other name of the factor 13 which stabilizes the clot? It's also known as clot stabilizing factor. Plasminogen. You see this thing, this ending? Ogen of genesis, of creation, of genesis, of creation. Fibrinogen creates fibrin. Plasminogen creates plasmin. Now, what is it that activates plasminogen into plasma? What in there in the bloodstream activates plasminogen? There's something in the tissue that activates plasminogen. What is it in the tissue that activates plasminogen? That would be tissue plasminogen activator. What is it in the tissue that activates plasminogen? Tissue plasminogen activator. But plasmin, this is why TPA only works on a fresh clot. It only works on a fresh clot and dissolves out fibrin Because after a while, fibrin gets cross-linked up and preserved by factor 13. Fibrin creates the clot. Plasmin destroys the clot. Factor 13 preserves the clot so the plasmin doesn't work. Clot creator, preserver, destroyer. Creator, preserver, destroyer. Where's my Hindus? Creator, preserver, destroyer. How interesting. Brahma, Vishnu, Shiva. Brahma, Vishnu, Shiva. Bahut acha, Sacham, Shivam, Asundaram. Wow. Look at that. Earth is crammed with heaven. Every tree is a burning bush. Those who see it will take their shoes off. All the rest can at least eat the blueberries. Earth is crammed with heaven. Every tree is a burning bush. Elizabeth Barrett Browning. There it is, a mandala inside you. The plaque ruptures. The platelets form. Give me an aspirin, baby. Give me an aspirin. The platelets form. They're going to get cross-linked up with fibrin. Give me some TPA, man, and hurry up, because we got to get that in there before factor 13 stabilizes it, preserves it. That's why you got to give TPA fast, because it doesn't work on old clot. It doesn't work on old clot because old clot gets stabilized by factor 13. Now you know everything I know. You don't need me anymore. Now all my works are overthrown. What strength I have is most faint, because now you know everything. Well, what is there to say about cardiology anymore? Look at that picture. That's disgusting. Look at that. I don't know. How would that looks tasty. How do you think that would look fried up with some onions, oregano, a little garlic? Ooh, I feel like having that on a roll right now. Taste it. Maybe stuffed with something there, a little peppers in the center. Ooh, yum. Yeah. Kind of fatty though, you know, it's a little fattier, but that is where the flavor is though. Yes, it's a cross section of my left ventricle, and this is an infarction. Yes, and in case you couldn't tell the white area, it was infarction. There's my nice circle. Okay, so blood cholesterol. If you have a person who's got coronary disease, the goal of an LDL is less than 100. So if you have a person with coronary artery disease, the goal is an LDL less than 100. An LDL less than 100. Now, if you have coronary artery disease and diabetes, please, the goal is less than 70. However, if it's coronary disease alone, the goal is less than 100. Now, tobacco smoking, remember that the fastest way to add 3 to 4 years to someone's life is to get them to stop smoking. In the average, if you got everybody to stop smoking in the United States, we have 3,000 people a week who die of lung cancer, and 6,000 who die of COPD. That's 9,000 per week, 450,000 a year. And if you have them stop smoking, that means that 450,000 people a year will not die of direct attributable effect to mortality to smoking. So the risks of smoking, those numbers don't even take into account its effect on cancer, other than lung cancer. So therefore, if you stop smoking, the risk is decreased in 2 years after cessation. It doesn't go all the way down to normal, but almost there. Now, the other risk factors, hypertension. The normal goal is a blood pressure less than 140/90, except in diabetes and renal failure, in which it's 130/80. Diabetes and renal failure in 130/80. So, hypertension is the most common risk factor for coronary artery disease. And systolic and diastolic are both bad. People say, oh, it's only this or only that. No, both of them cause a problem. Now, physical inactivity. This means that people who exercise regularly live longer. Wow, did you go to medical school to learn that? Hey, Mom, guess what I learned today? People who eat right, don't smoke, and exercise live longer. Yeah. Oh my goodness. Well, I hope we didn't have to go to medical school for that one. Call your mother. She'll tell you the same thing. Don't smoke, honey. Don't be such a fat, lazy slob. Eat better food. Take that bacon cheeseburger out of your mouth. Disgusting. Put some broccoli and some Brussels sprouts in. People who have more activity live longer. What a shock. Now, the other thing is that for every 100 people with diabetes, 25% can be controlled with diet and exercise. Physical activity. 25% of diabetics can be controlled with diet and exercise. There are 10,000 new diabetics per week in the United States. Wow. That's Socrates, the sense of wonder. It's the beginning of philosophy. That's the Greek way of saying, wow. It's the beginning of philosophy. 10,000 a week. Now, diabetologists go, oh, 3/4 of people are going to need medications anyway. And I go, that's 2,500 people a week I can keep off of medications. Wow. People pay the lottery where a lottery, a Powerball lottery with its $40 million payoff, if you buy 20 tickets a week for the next 20 years, every week, you'll win the lottery once every 400,000 years. And they still buy those lottery tickets. So therefore, this is a lottery where for every 4 tickets you win. And what do you win? Your life. Wow. 25% can be kept off medications with diet and exercise. 25% can be kept off diet and diet and exercise can keep you off of medications. Now, exercise is most likely to improve what? Exercise is most likely to improve which of the following? Which of the following is most likely to be improved by exercise? A 65-year-old sedentary obese man begins an exercise and weight loss program. Which of the following is most likely to be improved? Triglycerides, HDL, LDL, total cholesterol. HDL. The one that goes up the greatest in response to exercise, HDL. 65-year-old man who's a smoker stops smoking. Which of the following is most likely to improve? HDL. Lifestyle has its greatest effect upon HDL. HDL. All right, what else can we do? Obesity. In general, most of the effect of obesity, 10 to 20 pounds is huge. That's 5 to 10 kilograms. Most of the effect of obesity can be found by the fact that the more of you there is, the more likely there is to be diabetes and hypertension and increased lipids. However, even separate from the fact that obesity causes diabetes and hypertension and hyperlipidemia, obesity is still bad. It increases all-cause mortality. Now, in hypertension, for every kilogram lost, there is a millimeter of mercury improvement in blood pressure. Linear, reproducible. Ready? Which of the following lifestyle modifications is most likely to improve blood pressure? Diet, exercise, weight loss, relaxation methods. And the answer is weight loss. Weight loss is the most likely. First of all, diet. How do you measure it? Hey, did you keep your diet? Oh yeah, I kept to my diet. I did the seafood diet. What do you mean? I see food and I eat it. Did you use Dr. Fisher's special weight loss tape? Use it 3 times a day? Dr. Fisher's tape is guaranteed to have you lose weight? What do you mean? It's a roll of duct tape this wide. Put it on your mouth 3 times a day. Guaranteed. Breakfast, lunch, and dinner. Cover your mouth with tape. Guaranteed to lose weight. It's measurable. It's measurable. Relaxation methods? Sodium restriction? They don't do it. Relaxation. Who can measure it? Who can measure relaxation methods? Who can measure it? What'd you do this week? I went to Las Vegas. How'd it go? Well, I lost $18,000. I had a very relaxing time. People crave artificial fear, unmeasurable. Can't measure relaxation. How do you measure relaxation? Can't measure relaxation. People lie about their diet and their exercise. Weight loss is measurable and reproducible. For each kilogram lost, you lose a millimeter of mercury. For each kilogram lost, you lose a millimeter of mercury. Smoking has the greatest effect on HDL. Exercise has the greatest effect on HDL. Obesity does it through all these. 25% of people can be kept off of insulin with diet and exercise. Diabetes for LDL is the equivalent of a coronary arteries or ischemic heart disease. Diabetes is the equivalent from the point of view of LDL management. Coronary artery disease equals peripheral arterial disease. CAD equals PAD, and that is bad. Equals aortic disease, equals carotid disease, equals diabetes, please. And that is each one of them LDL less than 100. For any one of them, LDL less than 100 is the goal. LDL less than 100 is the goal. It's a coronary artery disease equivalent. Okay? Now, controlling the glucose does give a very measurable improvement. But as much as I control the glucose, it's not quite normal risk. It's not quite normal risk. Okay? It's not quite. Now remember, diabetes, number one cause of death, cardiovascular. Renal failure, end-stage renal disease, most common cause of death, cardiovascular, cardiovascular. What can't you control? You can't control how old you are. You can be childish, but you can't get younger. So remember that the majority of death in the United States, ready? In the United States, myocardial infarction kills as many people as Parkinson's, multiple sclerosis, depression, anxiety, motor vehicle accidents, gunshot wounds, multiple sclerosis, all put together don't kill as many as coronary artery disease. Men are at greater risk, but at the time you get to be 65 and 70, you have the same risk as a man. By the time you get to be 65, 70, a woman is the same risk as a man. So gender is only a risk early when the woman has recently had her menopause or menstruations. So a 50-year-old woman is at much less risk than a 50-year-old man, but by the time you get to 70, you've come a long way, baby, and you have the same risk as a man. Heredity. If you have a problem and you don't know who to blame it on, that's what we have parents for, okay? So therefore, remember, for it to be a family history, it has to be young. The male relative under 55, the female relative under 65. Remember, if mom and dad, your uncle, your grandfather, and your chipmunk and your dog all died at 80, it doesn't count as a risk factor for you. It has to be premature. Stress. The problem with this, with stress, hard to measure. People who are I mean, why am I alive? I mean, if stress was the most dangerous, this dangerous thing, I should have been dead by now. Okay? It's hard to measure it. Hard to measure it. Our first case is a 62-year-old man who has 8 months of exertional chest pain. 8 months of exertional chest pain that's been off and on and off. Exertional pain relieved by rest. Definition of angina, isn't it? Exertional pain relieved by rest. Definition of angina, isn't it? Now, as a 62-year-old man, he doesn't have to have risks. You'd consider that coronary disease anyway. But with diabetes and hyperlipidemia, dyslipidemia, oh my God, he's got everything except a tattoo on his chest saying, stenosis this way. The point of this story is this guy has a classic story and a negative EKG. So what do when you got a classic story and a negative EKG? You get a stress test. You get a stress test with a classic story and a negative EKG. Now the stress test is positive. Remember, the target of a stress test is ST segment depression. That's what he's got. ST segment depression. You're not trying to exercise people into ST elevation. That would be like exercising them into an infarction. And that's not nice. Nice people don't exercise their patients into death. So, when you have ST segment depression on the stress test with 8 months, the diagnosis is stable angina. Why stable? You say, wait a second, he's in angina. Yeah, but it's not changed in pattern. Unstable angina, unstable angina, unstable means by definition it is new. This is not new. It's been going on for 8 months. It's a worse pattern. It's a worse pattern. It's not worse. It's been going on unchanged for 8 months. Or pain progressing to the point where it's at rest. This is not at rest. This is not at rest. It's not at rest. Exertional, relieved by rest. Now let's see. Stable angina happens when you're exercising more than your coronaries can supply. Remember that the major thing is that ischemic pain, you see 5 to 15 minutes, not a second, not 5 hours. relieved by rest, and caused by exertion. Now, when we say atypical pain, do you see this word atypical pain? Atypical pain means pain at rest. Atypical pain means that it's not relieved by rest. Atypical pain means that it has no fixed pattern to exertion. Now, people who have stable angina typically have nothing particular on physical examination. An S4 gallop can mean that you have left ventricular ischemia, but you don't change anything based on the presence of the S4 gallop. That's atrial systole into a stiff, non-compliant ventricle. The EKG during the ischemic episode can have ST segment depression. If it has ST elevation, it's an infarction. If it has ST depression, it's ischemia. Now, what do we take as criteria as positive for an exercise tolerance test? A positive exercise tolerance test. All you need for an exercise tolerance test, one, is to be able to exercise sufficiently. What does exercise sufficiently mean? Meaning 220 minus your age is your maximum heart rate. You got to go to be able to get 85% of that max. You need to be able to exercise sufficiently. What do we mean by exercising sufficiently? Greater than 85% of your maximum heart rate. What's your maximum heart rate? 220 minus your age. Now look at the criteria. You develop hypotension. Hypotension, okay? A decrease in your blood pressure or ST segment depression. So it means I have to be able to read the EKG for ischemia. So how do I determine a regular exercise tolerance test? One, I need to be able to exercise. Two, I need to be able to read the EKG. One, I need to be able to exercise. Two, I need to be able to read the EKG. Now, I can't do a stress test if I have chest pain now. I can't do a stress test if I have instability of heart exam now. In other words, so instability means you're having chest pain now, you're having hypotension now, I can't do a stress test. The other thing is, what are you going to do if the person can't exercise? If you can't exercise, what are you going to do if you can't exercise? You have to have a pharmacological way of simulating the exercise. That is dipridamol or persantine thallium or dobutamine echo. That means you can't exercise, dipridamol or persantine thallium or dobutamine echo. I'm looking for decreased wall motion on the echocardiogram, and I'm looking for decreased thallium uptake on the thallium test. What happens when you can't exercise? I use dipridamol or persantine to pharmacologically simulate that exercise. Dobutamine should provoke decreased wall motion. Ready? Normal heart, move, bumpa, bumpa, bumpa. Oh, not ischemic, ischemic. Oh, normal, 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 normal. Ischemic, ischemic, oh, ischemic, oh, ischemic. So, if you have a baseline abnormality, a left bundle branch block, left ventricular hypertrophy, if you have a baseline abnormality, left bundle branch block, left ventricular hypertrophy, left digoxin effect, I can't read the EKG because I have a left bundle branch block. I have left ventricular hypertrophy. I have digoxin effect. I have a pacemaker in place. If you can't read the EKG, you have to have an alternate way of imaging the heart. And that is to use thallium or echocardiography. The normal stress test is based on one, I can exercise. Two, I can read the EKG. What if I can't exercise? I use dipridamol or I use dobutamine to be able to simulate the exercise. What happens if I can't read the EKG? I use nuclear studies or echocardiography to be able to detect the abnormality. Now, if I can't exercise because I'm on beta blockers or digoxin, in other words, how do I get up to my target heart rate if I'm on a beta blocker? How do I read the EKG for ischemia if I'm on digoxin? Digoxin causes downsloping ST segments, downsloping ST segments. Now, the story here about false positives in young females, this is really a statistical story. If we had a 70-year-old man with diabetes and hypertension, well, this guy, if he has exertional pain, wow, look, this guy, he probably has a 50% chance of having coronary artery disease. So let's say that there's a false positive rate on the stress test of plus or minus 2%. What if there's a false positive rate on a stress test, a plus or minus 2%? False positive, false negative. Wow, that means this guy, well, that means plus minus 2%. That means what do we got here? 52%, 48%. Well, you know what? If this guy's got a positive test, negative test, it's going to be real. False positive 2%. Now, what if we take a 30-year-old female? What's her chance of having coronary artery disease? Less than 1%. Now we take that same false positive rate of 2%. That means for every 3 people who have a positive stress test, 2 of them is a false positive. Here, a positive test, it's a real positive. Why? Very high pretest likelihood of disease. Here, low pretest likelihood of disease. This is a statistical question. If you take a group of patients that has a very low pretest likelihood of disease, you have a higher false positive rate. If you have a disease group that has almost no disease, even the most exquisitely accurate test becomes inaccurate. Let's take urinary beta-HCG, an extremely sensitive and specific test. And if I have a positive beta-HCG, which is an extremely accurate test, what's the chances my HCG is a false positive? Well, it's a very positive, very accurate test. Yeah, but you know what? I have a pre-test likelihood of disease of next to 0. So any positives to me is a false positive. The lower the pretest likelihood of disease, the greater the number of false positives. Prostate-specific antigen done on the obstetrical unit. A positive is a false positive. The lower the pretest likelihood of disease, the greater the number of false positives you'll have. Now, people with known coronary artery disease, if you have a negative test, it's a false negative. The greater the pretest likelihood of disease, the greater the false negative rate. If you have a bunch of people who are all dead and you do EKGs that show that they're normal, well, it's a false negative rate. False negative rate, the opposite. Let's take a look here. 29-year-old woman has a routine stress test that shows 1 millimeter of ST segment depression. No history of chest pain. She's exercising and running 3 times a week. Physical exam is normal. What is the most likely cause of her abnormal stress test? A 29-year-old woman that's a jock and can run. The chances that this test is real is essentially 0. It's essentially 0. It's going to be a false positive test. Why? Because she has no pretest likelihood of disease. So the other thing about nuclear stress test, nuclear is either thallium or sestamide. Thallium or sestamide. Thallium. What does thallium look like to a myocyte in the heart? It looks like potassium. It looks like potassium. So if you inject the thallium, as long as the cells are perfused and they are alive, you should pick up the thallium. As long as they are perfused and they are alive, they should pick up the thallium. So the radioactive material should pick up because it looks like potassium. Now, if your ischemic myocardium is not perfused, you have decreased thallium uptake. If the cells are ischemic, decreased thallium uptake. If the cells are dead, decreased thallium uptake. Now, how are we going to tell the difference between decreased uptake from ischemia or decreased uptake from infarction? How are you going to tell ischemia, insufficient perfusion, from infarction, dead tissue? How do we tell them apart? The answer is reperfusion, images, at rest, you wait, you wait, you wait, does it pick up later on? Now, the most important thing that we're looking for is people who have reversible defects. In other words, at exercise, I have decreased thallium uptake. At rest, the thallium picks up, the thallium picks up, the thallium picks up. At exercise, decreased uptake. At rest, the thallium picks up. That means a reversible defect. That's the number one thing we're looking for. And why is it the number one thing we're looking for? Because it's the thing that gets bypassed to and reperfused. Bypassed and reperfused. Now, The main thing about nuclear stress testing is that it doesn't get affected by the EKG. As a matter of fact, if you have an abnormal baseline EKG, it is exactly the test to do. What do you do when you think you have ischemia, but you can't read that EKG? Thallium or sestamib. Now, dobutamine or adenosine stress testing is based on the fact that dobutamine, as a positive inotrope, will cause increased contractility. Dobutamine as a positive inotrope will cause and provoke ischemia. Dobutamine is an inotrope, contractility, provoke ischemia, and ischemic things stop moving. So on a thallium stress test, on a dobutamine stress test, during exercise, you should see decreased wall motion with dobutamine and with the use of exercise. Now, you see this abnormal myocardial movement? That is because it's ischemic, and ischemic things do not move. Now, when I have a positive stress test, I am going to do a stress test. I am going to do angiography, a catheterization. What's the point of that angiogram? What am I going to do differently based on that angiogram? What's the point of that angiography? What am I going to do differently than angiography? What am I doing this? And the point is, angiography is to answer this question. Should I bypass or not? What is an angiogram? It's a cardiac surgery screening device. Let's see. You use it in patients who are going to need the evaluation for bypass. So the question comes down to this. When does bypass lower mortality? When does bypass lower mortality? 3-vessel disease or left main coronary disease. 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 How do I know? How do I know? I can't tell it's 3-vessel or left main unless I get a angiogram. I can't tell if it's 3-vessel or left main unless I'm catheterized. So what's the point of being catheterized? I take people with positive stress tests and see if they need to be bypassed. Angiography is used also if, what do you do when you have an equivocal stress test? Angiogram. Stress test that's positive. Equivocal stress test. And they use it to be able to determine, see this where it says stent placement? Stent placement is what you do if somebody has 1 or 2 vessel disease. I have 1 or 2 vessel disease, and should I do angioplasty? Angioplasty always goes with a stent. Angioplasty always goes with a stent. I balloon it open, and I keep it open with a stent. I balloon it open, and I keep it open with a stent. I balloon it open, and I keep it open with a stent. That's what the angiogram is for. Angiography says this. What am I going to do differently based on the result of this test? What will I do differently based on the result of this test? That's how I study. Why am I getting the stress test? Because I want to see who to cath. Why am I cathing? I want to see who to cut. Why am I cutting? I want to see who'll live. I want to see who'll live. Working backwards, it says this. Which of these things can help me lower mortality? I want to know when to bypass or do angioplasty. Bypass only lowers mortality in the most severe disease. Hippocrates said, dangerous diseases require dangerous cures. So therefore, the most dangerous disease requires the most dangerous cure. Extra bonus points for the brand new car in the dream home in Malibu. The other indication is 2-vessel disease in a diabetic, please. 2-vessel disease in diabetes also can be bypassed. 2-vessel disease and diabetes. Let's see some treatment. Well, sublingual nitroglycerin on that treatment. Let's see. Guy comes to the emergency room and he's got some severe chest pain. We got a 70-year-old guy. He comes to the emergency department and he's got some chest pain. He's got some chest pain and he's got some ST segment abnormality. Got some chest pain. Sublingual nitroglycerin is good. Beta blockers are good. Aspirin is good. Statins are good. Risk factor modifications are good. However, which of these is the goodest? A guy comes and he's got ST segment elevation and chest pain. What's the next best step in the management of this patient? What's the most important action at this time? Nitrates should be given. Oxygen should be given. Statins should be given. But aspirin lowers mortality and beta blockers lower mortality. Statins will lower mortality if the LDL is above 100. When are you going to answer clopidogrel? Clopidogrel. Plavix. When are you going to answer clopidogrel or Plavix? When you can't take aspirin. When you can't take aspirin. So you see all these things here, nitrates, beta blockers, aspirin, statins. They're all good, but aspirin and beta blocker are the goodest. Why? They lower mortality. They lower mortality. Now, the guy has coronary disease. Should we give him statins? Well, it depends. It depends on the circumstances. What is the target for coronary disease? Is an LDL less than 100? What's the target for HDL? HDL is targeted above 40. However, the HDL by itself is not clearly lower mortality. We want the LDL lower, but the triglycerides also low. However, lowering the triglycerides is not the greatest mortality and benefit. Which of the following is most likely to affect mortality? Raising the HDL, lowering the LDL, lowering the total cholesterol, lowering the triglycerides. Which of the following is most likely to lower mortality the most? The answer is LDL is the best. Better than raising the HDL, better than lowering the triglycerides. Now, very high risk. See this word for very high risk? Very high risk means coronary disease and diabetes. Coronary disease and tobacco smoking. That's under 70. Coronary disease and tobacco smoking. Coronary disease and diabetes. Acute coronary syndromes. What is very high risk? It means that you've got to have multiple things. This is hard for people. Coronary disease and its equivalents, under 100. But coronary disease and diabetes or acute coronary syndromes, under 70. Now, why is statins first? In other words, let's look at all the therapies that we have for LDLs. Let's look at all the therapies that we have. Statins lower LDL, but so does niacin lower LDL, so does gemfibrozole and fibric acid derivatives. Oh, so does cholestyramine, and so does ezetimibe. These all lower LDL. Which of these will lower the total cholesterol? All of them. Which of these will raise the HDL? All of them. Which of these will lower the triglycerides? All of them. So why is statins first? Why is statins first? Statins is first because statins have the greatest effect on mortality. Statins have the greatest effect upon mortality. When do I bypass? I bypass, oh, look at this. Left main coronary, 3-vessel disease. And the very, very, very worst thing is 3-vessel disease and left ventricular dysfunction. Why bypass? Because the sickest heart needs the greatest amount of reperfusion. The sickest heart needs the greatest amount. You see where it says more efficacious in diabetes? Because by definition, diabetes and vascular disease is much worse. Diabetes and vascular disease is much sicker. The sickest heart needs the greatest perfusion. Diabetes is a sicker heart. Okay, diabetes and ischemia leading to decreased ejection fraction. Who needs the biggest cure? The one with the illest disease. 3 vessels, left main, low ejection fraction, diabetics. They're starving, man. Intervention. You see this word, percutaneous coronary intervention? Angioplasty is one type of percutaneous coronary intervention. I like that word, intervention. Wow. Well, intervention was a term used because we thought we were going to have a half a dozen different things to do other than just balloon you. Mostly it means angioplasty, because that's by far the most common intervention. It's what you do for the other people who don't have three-vessel disease. A stent is a tube placed into the coronary artery. It can be coated with medications to prevent the restenosis. Our biggest enemy in angioplasty is that without a stent, 1/3 restenose. With the stent, 1 out of 5 restenose. What's our point here? Balloon, stent, and give meds to try and keep it open. Heparin, clopidogrel, aspirin, heparin, clopidogrel, aspirin, heparin, clopidogrel. Let's try and keep that thing open. Well, that's the end of ischemic heart disease. The most important thing is, when a person comes to the emergency room with chest pain and ST elevation, the first thing is, which of the following drugs lower mortality? Aspirin lowers mortality. Beta blockers lower mortality. Thrombolytics lower mortality. Angioplasty lowers mortality in primary angioplasty. What lowers mortality? It's 3 days before the exam. I don't know what to do. I'm having a small cow. Hello, little cow. What do? I review the drugs that lower mortality. Aspirin lowers mortality. Beta blockers lower mortality. TPA lowers mortality. Angioplasty can lower mortality. Clopidogrel can lower mortality. Oh, you bitter hug of mortality, I draw you near. They all lower mortality. What do you think the board is going to want you to know? How to draw the chemical structure of verapamil? How to spell guaiac? What would you want you to know? What lowers mortality? Statins will lower mortality if the LDL is high. ACE inhibitors will lower mortality if the ejection fraction is low. Clopidogrel lowers mortality. Yes, it does. When are you going to answer ticlopidine? When is that the answer? Never. Ticlopidine causes adverse effects. Ticlopidine causes adverse effects, so don't use it.